So next is Karan. Karan is here.
Good morning, sir.
Hi,
Yes, sir, I'm here.
welcome. Welcome.
Good morning.
Yeah,
Thank you, sir.
we look forward.
So, can I share my slide, sir?
Yeah, please go ahead. Karan, you are in
On
Jaydeva,
my-
Bangalore, right?
Yes, sir. Yes, sir.
Okay.
It's actually a peripheral center of Jaydeva, sir. It's in North Bangalore. Recently started around 2 years
How
back.
many peripheral centers of Jaydeva are there?
I think around four, sir. Four. One in Mysore, one in Gulbarga, one in ESI Bangalore, and this is the fourth one.
But
It is
I
in
know
a small
one thing of
hospital.
Jaydeva. They do huge volumes, right?
Yes, sir. Yes, sir. Very huge volume, sir. Total bed capacity of Jaydeva, including all the peripheral centers, is I think around 1,700, sir.
Okay.
Only for cardiac cases.
Okay. Please go ahead, Karan.
Okay, sir. So I'm going to present a case of aorto-ostial LMCA dissection causing acute left main closure. I have named this case as threading the eye of the needle. We'll get to see why I have named it like that. So the patient was a 60-year-old male, non-diabetic and hypertensive, who presented with an evolved anterior wall MI. On echo, there was hypokinesia of LAD territory and thickness was preserved, and the ejection fraction was 45%. So this was the angiogram. You can see that the osteoproximal LAD has total occlusion, and the mid LAD is very faintly opacified through collaterals from the left side. From the right side, actually, there are retrograde collaterals opacifying the distal and the mid LAD. So the plan was PTCA to LAD, but due to some financial constraints, the patient was not willing. Uh, so he came back after a month with some chest pain, and he was that time willing for PTCA. So we took him up for PTCA. The LMCA was engaged with a 6 French EBO 3.5 guide catheter, and check angio showed that there was some amount of antegrade flow in the LAD, around TB1 flow. And so we tried wiring with multiple wires. First choice was BMW wire. We escalated to the choice PT wire, then the pilot 50 wire, and then a pilot 200 wire also. But since there was an acute angulation between the LM and the LAD, we were not able to enter into the LAD. So after trying for some time, patient started complaining of chest pain, and his BP started dropping. And we took one shoot, and this was actually the site. It was a terrific site actually. The check angel showed LMCA dissection with acute left main closure. The LCX actually was a very big vessel and was supplying some amount of the LAD territory also. So the patient started complaining of immediately of chest pain and BP started dropping. Inotropes were initiated. Then multiple attempts were made actually at wiring the LCX, but the wire kept on entering the dissection plane. We were not able to enter into the true lumen. Then finally a BMW wire was able to cross distally. Since we didn't have IVUS to confirm the position of the wire in true lumen, we decided to use an aspiration catheter to take the catheter distally beyond the plane of dissection and give a small injection to see whether the branches are opacified to confirm the wire position. But I think that was a mistake from our side, because as soon as the aspiration catheter entered the LMCA, patient started developing ventricular fibrillation. So the patient had multiple episodes of VT and VF, was cardioverted almost 12 times, and he was intubated and mechanically ventilated. And each time cardioverting, everything was getting disengaged. The EVO catheter was getting disengaged. So each time we had to re-engage and try to wire again. So finally, actually, the BMW wire went in a loop and it went distally into the major OM. That is the time we thought that yes, it is most likely the true lumen. So then we didn't waste much time. We took a 3.5 into 48 mm everolimus saluting stent and deployed it from the ostial LMCA to the major OM. And actually, in a fluoro shoot, there was some dye hanging in the aortic cusp also. So we thought that maybe the dissection has extended retrogradely, causing some amount of aortic dissection also. So that's why we placed a stent from the ostial LMCA to the major OM. Then we post-dilated the stent with 4 into 12 mm NC balloon, and a part and ostial flaring was done with a 5 mm balloon. So final check angio showed well expanded stent, TIMI3 flow, but the part of the LCX after the stent looked small in caliber. We felt it is most likely due to external compression from the intramural hematoma, since the dissection had extended up to the major vein. So since this was a very big vessel, we decided to cover that part too. So we put one more overlapping 3 into 40 millimeter everolimus saluting stent, crossed with guide liner support and deployed distally to the first stent, post-dilated with a 4 into 12 mm NC balloon. So this was the final result. Patient BP improved immediately. Then the patient was extubated after 12 hours. Hemodynamics stabilized over the next 24 hours. The patient was discharged on third post-operative day. LAD, we thought we will tackle it later, not presently. So take-home messages, iatrogenic LMCA dissections are rare with a reported incidence of less than 0.2%, but it is one of the most catastrophic complications of PCI with potentially fatal outcomes. The factors that can increase the risk of developing LMCA dissection include significant atherosclerosis, inappropriate catheter selection, deep intubation of guide catheter, forceful manipulation of the guide catheter, forceful injection of contrast medium, the use of stiff coronary guide wires, and an inexperienced operator. To restore flow in LMCA, it is pivotal to wire the true lumen as soon as possible. That there are two ways of confirming the position of the wire in the true lumen. Best is IVUS. Since we didn't have IVUS, we planned for the second way. It was injecting distally into the coronary artery through an aspiration catheter to opacify the branches, but it carries the risk of expansion of the dissection plane. Thank you.
Thanks, Karan. It was audacious case. I mean, do you think it was the guide catheter which was the culprit?
We feel it was the wire, sir, since it was a
Which wire was
pilot
that?
200. Pilot 200, sir.
Okay.
There's a
Yeah.
high tip
So,
load.
so yes, because the LED wiring was very tough, so it may have encroached upon the endothelium in the left main, and then the dissection just spread.
Yes, sir.
Yeah. So then, it was a terrible sight for any interventional cardiologist where everything starts occluding, and then, your catecholamine level is very high, and you have to have, you want to maintain your cool, but it's very tough. And then you keep
Yes, sir.
trying various options. Then, in your case, you mentioned patient had multiple VT/VF runs. Not easy in
Yes,
that
sir.
scenario. So I think as a pilot, you keep holding the center stage and have more hands for your assistants. You should have one or two assistants, one or two nurses, somebody
Yes,
start.
sir. Actually, the whole team was inside the cath lab. There were,
I know,
we
I
are a
know.
team of 4 cardiologists. All four were inside the cath lab at that time.
Ah, so I know. Somebody starting
One,
noradrenaline drip, somebody ready to intubate the patient. So all those
yes,
stuff
sir.
happens, not easy, but very well done in the end. To salvage such a patient where the going has gone very tough and horrible stuff has happened. That is the test of real patience and real skill. Good, Karan. Very well done.
Thank
Very
you.
well
Thank you
done.
so
This
much.
was this was extremely interesting case. Very exciting.
Thank you so much.